Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I will be your host this evening. Given that this is a Tuesday, we will be doing cases from folks' lists. So tonight is Tuesday, September 13th, 2022. We will be going till 10 o'clock Eastern time tonight as well. So hopefully you have an hour and a half that you can spend with us. I will ask for volunteers in just a second. If you have had a chance to be in the hot seat, certainly last night, and I would say even Sunday night, please let your colleagues have an opportunity to volunteer. If we don't have enough volunteers, happy to take folks who went last night or the night before as well. So I think having said that, let's get started. So does anybody want to volunteer? Aaron? Are you volunteering? Says you're self-muted.
Hi, sure.
Thank you for volunteering. How are you?
I'm good. How are you?
Doing well, thanks. Are you a generalist or specialist?
I'm a GYN oncology fellow.
Okay. All right. Of course, we're going to end up doing OB, right?
Yeah, I was going to say we can do OB or office, whatever you like, but we can skip GYN for now.
Sounds like a plan. Well, let me just find a case for you.
Thanks.
So let's see. Patient number 4 is a 29-year-old G2P0 at 39 in a day. She's breech and she had a primary C-section. Baby had good APGARs and weighed 3,060 grams. Tell me, do you offer external cephalic versions?
I do. I actually just sort of reviewed ECV in this case with a former attending of mine from residency. Would it be possible to maybe choose a different one? That's the only one I've reviewed very recently, but I feel like I just went over all the ECV things.
Okay. Let's see. No, that's fine. Patient number 13 is a 33-year-old G2P0 at 39 and 1 with chronic hypertension. She had an induction of labor and a vaginal delivery. So why did you let her go to 39 weeks with being chronic hypertensive?
So this patient was a chronic hypertensive who was not on medications, if I recall correct. So she had a diagnosis prior to 20 weeks, but didn't require any medications in the in her pregnancy, and so went until 39 and 1 week.
So if this patient came to you for a new OB visit and she was on, let's say, losartan, which is an ACE ARB, what would you have done with her at the new OB?
So ACE inhibitors can be teratogenic, so I would have wanted to swap her off of that and onto something that is known to be safe in pregnancy, which would include labetalol or nifedipine or methyldopa.
So what's the concern with ACE ARBs in pregnancy?
They can definitely lead to renal problems for the fetus, which can ultimately lead to like oligo or anhydramnios, Potter sequence, and the subsequent sequelae from renal dysfunction. But I believe they can have some other teratogenic effects. I want to say cardiac, but I know renal is certainly one of the large concerns.
Okay, you mentioned nifedipine. What's the mechanism of action of nifedipine?
Nifedipine is a calcium channel blocker, so it's going to work to essentially lead to vasodilation, which will ultimately lead to a lower blood pressure systemically.
So what about, you mentioned labetalol. What's the mechanism of action of labetalol?
Labetalol is a beta blocker, so its effect is going to be both cardiac in terms of rhythm, so it can slow heart rate down, but also can work in the systemic vasculature to lead to vasodilation as well, since it's working against the beta receptor to prevent vasoconstriction.
So, first of all, does labetalol have any other property other than beta blockade?
I believe it does, and I'm remembering back to my med school days, but I'm not sure if it also has some epinephrine antagonistic effects, but I wouldn't feel comfortable guessing. I believe it does, though.
So how would you answer that from the board, from a board perspective?
Good question. I would say that I believe it does have additional effects other than being a beta blocker, but I wouldn't know offhand what they are. I'd have to check.
Okay. What about what would you do if you had a patient who, let's say she delivers, let's say this patient delivers, and they call you about 2 hours later saying the patient's blood pressure is 185 over 130. What would you do?
So I would certainly be concerned that this is now progressing to superimposed preeclampsia, and I would want to first control her blood pressure. If it's this patient and she's not been on medications, then first line we could use labetalol or nifedipine. If she has an IV, labetalol 20 milligrams IV could be used. If she doesn't, then we could use nifedipine 10 milligrams PO. We could also use hydralazine IV 10 milligrams.
What would you use?
If she has a history of asthma or reactive airway disease, I wouldn't use labetalol, but otherwise labetalol or nifedipine are usually the two that I would go to first. I think in terms of the diastolic being as high as it is, I think there may be some benefit to using hydralazine. It may have a better effect on that diastolic blood pressure, but I don't think there's any proven difference between them. I think you could use any.
All right, so from a technique standpoint, Aaron, do we really want to bring all that up?
No, I don't.
So are you familiar with the KISS principle? Keep it simple, silly, and some might substitute the S, the last S. So if we're not certain of things and we're answering the question, we don't want to bring up other things that we're not certain of, again, if we've answered the question adequately. Yeah. Because then you're exposing what you don't know. So, you know, we wouldn't want to necessarily volunteer that, if that makes any sense.
That sounds good. So I would say then any of the three would be fine to use.
Okay, so which one would you select?
I'd probably start with labetalol 20 milligrams IV.
Okay, and then when would you recheck her?
Her blood pressure, I would recheck in 15 minutes, and then if it's still in the severe range above 160 over 110, I would go to 40 milligrams IV.
Okay, and how long would you wait between doses?
I believe 10 to 15 minutes.
Okay, so you go to 40. Let's say after giving her 40, her blood pressure is 170 over 126.
Then I would go to 80 milligrams IV.
Okay. This, again, getting back to this particular patient, by the way, anything else you would do with that patient other than giving her the antihypertensives in an emergent fashion?
I would probably send off some blood work to evaluate for other potential end organ damage of this likely superimposed preeclampsia, so including her creatinine and LFTs and platelets.
So you're probably going to send, what labs are you probably going to send?
I am going to send all of those labs.
Okay. Anything else you're going to do other than check labs?
I'm going to see if she has any other symptoms like a headache, right upper quadrant pain.
Does it make a difference?
It would. I could treat her headache if she has a headache. But I think regardless with all of these blood pressures, the last thing I would do is start magnesium sulfate.
All right. So how much would you give?
For preeclampsia, I would start with a loading bolus of 4 grams over about 30 minutes, and then 2 gram maintenance after that.
Aaron, you like to qualify things, don't you?
I'm not hearing it because I'm in the hot seat, but that's good to know.
Okay. Yeah, I think you said something like over about 30 minutes or something like that. Okay, so let me change the scenario just one more time. So let's say this particular patient, when they call you to the recovery room, let's say she didn't have an IV, she delivered vaginally and was fairly uncomplicated, so they took out the IV. Let's say it either got infiltrated, whatever, she was stable, so they didn't replace it. In any case, they call you with this blood pressure. While you're on your way to see the patient starts having a seizure, but has no IV access. What would you do in that case?
So specifically with regards to your question and giving magnesium, you can give it IM 5 milligrams sort of in each buttocks. But in terms of the rest of her seizure management, would you like me to go through that? Or were you just asking about the magnesium?
Well, I'm curious how you would treat her acutely. You said 5 milligrams in each buttock?
Yes.
Are you sure?
Yes.
Are you willing to bet your boards on this?
Yep.
Okay, we'll see you next year, buddy. It's 5 grams in each buttock.
Okay.
You said 5 milligrams. It's a common mistake, but it's an important mistake. Think about your units, guys. People do this with folic acid sometimes as well. So the units are important. Okay. I think we'll stop here, actually. So nice job. ASARBs, super early in pregnancy. Not that we would recommend it. We would definitely change a person's antihypertensive, but if they're super early and pregnant, probably hasn't had any untoward effects. Certainly not really recommended in any of the trimesters. Concern later in pregnancy can, as you mentioned, oligohydramnios, fetal growth restriction would be something else. Obviously, renal anomalies would be something that we would be concerned with. So in terms of the labetalol, the majority of its properties are beta blockade, but it does have some alpha blockade properties, which, if I'm not mistaken, take a little longer to kick in, but there are some alpha properties as well. In terms of the blood pressure that I mentioned to you, excuse me. So, treating the patient's blood pressure is fine, but really what we would say is we would start the patient on MAG straight away. The labs are fine, whether we want to try to call this, superimposed preeclampsia, or whether we want to call this, chronic hypertension with a severe range blood pressure exacerbation. It doesn't really matter. I mean, maybe for a diagnosis code it does, but it doesn't matter in terms of how we're going to manage the patient. We would still start her on magnesium. So that's kind of the critical point. Certainly nothing wrong with getting labs, in terms of, place to start for monitoring purposes. but still in all, we would want to make sure we mention the MAG. The headache thing is certainly fine. Obviously, you're going to try to treat the headache after you stabilize the patient. Your MAG was fine again, except for the units. So 5 grams in each buttock would certainly be an option. You could use a benzodiazepine as well. I want to say Ativan 2 grams, but someone feel free to fact check me on that one. And, you know, for giving something acutely, that would be appropriate. Things like Dilantin, obviously, we're not going to give acutely because, first of all, we're going to need access for it. And second of all, you know, you've got to give it slowly. It's got to be loaded. It's going to take time to get a level. So not going to be the best thing for an acute situation. Other things you could consider, but not necessarily in an acute situation as much, would include phenobarb if you were going to put somebody on an alternative, you know, for a little longer term treatment, especially after the delivery. Trying to think. Oh, your management in terms of the hypertensive emergency was fine. 20 milligrams followed by 40, followed by 80. You could give 80 times 2, and then you'd want to switch to a different antihypertensive. And you mentioned nifedipine and hydralazine as options, which are both correct. You would wait typically approximately 10 minutes, 10 no more than 15 if you were talking about labetalol. And of course, remember to mention if you're using hydralazine, you're going to want to push it slowly, usually over 2 minutes. Any questions, Aaron?
No, thank you. That was good. And always a good reminder about sticking to just the answer.
Sorry, everybody gets the units thing wrong with the with the IM MAG. So I'm sure you won't. Thank you very much.
You're welcome. Thanks.
Okay. Thanks. So guys, if y'all have questions, you know, you can type them in the box or you can hold them. What I'm going to do is at around 9:10, whenever we finish the case around that time, I will pause, ask for questions about anything we've covered. So we'll put everybody's hand down at that time, and then we'll ask for people to re-raise them after we go over the questions, and we'll do it again at the end. All right, so Matthew, looks like you're volunteering.
Hi, yes.
So are you a generalist or specialist?
Generalist.
Okay. Let's see what we can bring up for you. So patient number 8 is a 30-year-old nulliparous patient with abnormal uterine bleeding. She has premenstrual dysphoric disorder and dysmenorrhea. You did a history and physical. She declined an ultrasound. You recommended lifestyle modifications and put her on continuous birth control pills with improved symptoms after 2 visits. So tell me, when you have a patient, first of all, what are signs and symptoms of PMDD, and how do you make that diagnosis?
So for patients with PMDD, they typically have, well, they will have severe personal conflict, mood swing.
Severe what?
Like personal conflict, interfering with their personal life. Sorry, I had to change some background noise here. Mood swings, mood changes, crying episodes, so extensive mood abnormalities surrounding their menses, and it's usually on a cyclic basis.
Are there any physical findings that can be associated with PMDD, or what we used to call PMS?
So patients will typically have, or can have, abdominal pain, cramping, bloating, those kinds of things.
Okay. So I assume that you make this diagnosis based on history pretty much?
Well, she actually came in with the diagnosis of PMDD. She had been previously diagnosed and she had not had good control with her previous provider, so she was essentially seeking a second opinion.
So what medical treatment options would you have for a patient with PMDD?
So including in this patient, we discussed lifestyle modifications. So she was very active in the outdoors, so we encouraged increased sunlight
Well,
exposure.
let's talk about medications first.
Oh, sorry. So we discussed continuous, oral contraceptive pills and SSRIs or SNRIs, primarily SSRIs for her, if she were considering that.
Okay. I see that it says that you put her on continuous combined birth control pills. Is there any particular pill that you would think would be better for a patient that has PMDD as compared to somebody who doesn't have these mood disturbances?
For most of these patients, I consider something like a low estrin, just because they don't require an anti-androgenic effect, say in somebody with PCOS.
Well, what would you put somebody with PCOS on?
They would have a oh my gosh, I'm totally blanking on the progesterone component of that. Oh my gosh, I can't recall at this time. Sorry.
I'm sorry, for which progesterone are you trying to recall?
I can't recall at this time. I apologize.
Right, but I'm sorry, you're trying to recall a progesterone that is
has mild
yeah,
androgenic.
Okay. So, all right. So you said you might use low estrin in this patient. What's the progesterone in low estrin?
It is norethindrone acetate.
Okay. All right, continuous birth control pills, and then you mentioned SSRIs. I assume you did not put this particular patient on SSRI, is that right?
That's correct.
If you had put her on SSRI, how do you normally prescribe them? Do you use them cyclically? Do you use them continuously? And why?
I typically use them continuously, just because in my practice, I've noticed somewhat more beneficial effect, given that some patients with PMDD also have a depressive, not just cyclic depression, but also some component of depression or anxiety outside of menses. So I usually prescribe them continuously, and I start with typically an SSRI like Zoloft, sertraline, starting at the lowest dose, 25 daily, although the lowest effective dose is usually about 50 milligrams.
Okay. It says lifestyle modifications here too. Excuse me. What lifestyle modifications would you recommend?
So we encouraged, or I encouraged her to pursue outdoor activities, exposure to sunlight. Also, physical activity and exercise can release endogenous endorphins, essentially, possibly improving her mood. Also, having a good social support and social network. And there are also a good diet to avoid ultra processed foods. Sometimes have that's not necessarily guideline based, but it does have some effect of she was not necessarily obese, but she was overweight, so we also encouraged weight loss for her.
So diet, avoid ultra processed foods, exercise, social support, and weight loss. Anything else for your lifestyle modifications?
increased activity, being outdoors, sunlight. Those are pretty much the main things we started with.
Okay. All right, I think we'll stop here. All right, so nice job. Let's talk about this one. So, certainly there is the emotional component, which I think you covered well. The mood changes, crying spells potentially, typically cyclic. They may have difficulty in their personal relationships, as you noted, around the time of their cycle. But you also mentioned abdominal pain and bloating, which of course can go with it, but so can breast tenderness as another example. So the birth control pills, I was a little surprised you said low estrogen with the norethindrone. I mean, norethindrone is not a bad progesterone by any stretch of the imagination, but it wouldn't be the first one I would think of for a patient with PMDD type symptoms. I would think that you might want to consider something like just a drospirenone containing birth control pill,
Okay.
like or something like that. First of all, it's going to have some diuretic property. So if the patient does have bloating as one of their side effects, one of their symptoms, the drospirenone should help with that. Not to mention, as you said, it's not going to because it's a newer generation progesterone, it shouldn't have the occasional depressive symptoms that can be associated with some of the older progesterones. Of course, not to mention the lack of androgenic side effects with drospirenone. But the big thing would be the mood and the diuretic properties. I thought your explanation regarding recommending continuous SSRIs, and either is fine, as you know, is good. One other thing to consider would be NSAIDs. May help with some of the menstrual flow, certainly may help with some of the cramping. Again, it really depends on the exact symptoms the patient has with the PMDD. If they're all pure, I don't say purely emotional, but, purely mood related, it's probably not going to be your best choice, but it would be something else, to consider. Exercise is good. Diet. So in diet, I've seen two different things. One to increase carbohydrates and one to decrease carbohydrates. Most recently, I've seen the decrease in carbohydrates is recommended. I would suggest that avoiding things like excess sodium intake, again, to help with to help eliminate the water retention that patients may experience, as well as, and this is going to be a little bit more anecdotal, but reduction in caffeine. The idea behind the caffeine is, in terms of breast tenderness. Again, I know with fibrocystic disease, caffeine has not been proven to be directly related, but I can tell you certainly with a fair amount of anecdotal experience, patients often do have more fibrocystic complaints and changes with caffeine. So it's certainly not going to hurt the patient to avoid the caffeine, particularly around the perimenstrual time frame. So I think that is it. Any questions, Matthew?
No, I think that works. Thank you so much.
Thank you. Thanks for volunteering. Okay. Let's see who. Melissa, are you volunteering?
Yes. Hi.
Hi, how are you?
Good. How are you?
I'm doing well, thanks. Are you a generalist or a specialist?
A generalist?
Okay, give me a second to get to your list. And there you are. Okay. All right. So I can't resist, I'm sorry. Patient number 5 is a 28-year-old G2P2 who's postpartum day 1 from a vaginal delivery performed by one of your colleagues who desired sterilization. You did a postpartum tubal with cross-sections of bilateral fallopian tubes. So did you do a salpingectomy here or did you do a partial salpingectomy?
I did a partial salpingectomy.
Which type of partial salpingectomy did you do?
I do a parkland.
How come you do parkland?
So on for one thing, as far as for postpartum tubals, which are done through like a mini laparotomy incision the day after, I personally feel more comfortable doing partial salpingectomy, especially with my small operating area and visualization. Parkland is also what I feel comfortable with as far as being able to grasp a good portion, usually about like 2 centimeters worth of tube on each side, as well as so accuracy as far as proper excision and less. I don't tend to have very many issues as far as like bleeding of the mesosalpinx from doing it in that method. So that is my preference.
As compared to doing what other method?
As compared
You said you don't have
to
bleeding from the so.
as say compared to attempting a as compared to attempting a full salpingectomy on postpartum day 1 through mini laparotomy incision.
So when you do a parkland, can you describe for me how you remove that segment of tube?
Sure. So I identify the fallopian tube starting at the uterine cornua all the way out to the fimbriated edge. I grasp the tube usually with a Babcock. I slightly enter the underlying mesosalpinx with cautery, and then using 2 pieces of plain gut on each side, I'm able to then tie off. I usually try and take about a 2 centimeter portion of tube near the like the isthmus region, and then cut this area away and make sure that the remaining portions of tube are hemostatic.
So if you're concerned about and you do a partial salpingectomy to reduce the chance of bleeding from the mesosalpinx, how come you do a parkland and not a pomeroy, where you don't actually have to enter the mesosalpinx?
That's a good question. I just have more personal comfort level with doing the Parkland method in that way.
So if you were to do a salpingectomy, how much would you reduce this patient's future risk of ovarian or peritoneal cancer?
So if I were doing a complete salpingectomy, I believe I'd be reducing her chances by about 65%.
I'm sorry, can you tell me 55 or 65?
65.
Okay. And so when you have a patient that comes in requesting tubal sterilization, are there any other options you offer the patient?
Sure. I first, prior to reviewing the options, I've reviewed also the patient's personal medical history, as well as a discussion with them as far as other forms of contraception, such as LARCs and OCPs. And also make sure that I gather an understanding from the patient that they desire no more children in the future. Following that discussion, I tend to talk, unless they are in the immediate postpartum period, I speak with them about salpingectomies.
Okay. Um, can you tell me what are risk factors for regret?
Yes, so age is certainly a big one. I believe a monogamous relationship and low parity can be considered.
Low parity is defined how?
I would say less than 2 live births,
Okay, and what age?
less than 30.
Okay, so we have age, parity, non-monogamous, anything else?
That's what I can think of right now.
Okay, all right, good. Let's go over it. So I'm going to just kind of move around a little bit, and then we'll cover the whole thing. But
Sure.
so bilateral salpingectomy, I've seen numbers all over the place. I would probably personally say about 50%, but I've seen 40 to 60. Occasionally, we've even seen a higher number. You know, partial salpingectomy obviously is going to be lower, but I mean, I don't have a major problem with the 65%. It's a little higher than I'm familiar with, but again, it's such variation depending what you read. I don't think you're way off base. The one thing I would encourage you, and I would tell everybody on the call, if they ask you what alternatives do you discuss with patients, they know you know how to counsel patients regarding general contraception, like LARCs, hormonal manipulation, barrier methods, and whatever, because you do that, a ton of that stuff every day. What they want to hear you say is they want to hear you mention vasectomy for partner.
Gotcha.
They want to make sure we don't have tunnel vision and we're just, oh, well, it's our patient, we can do a procedure on her, whatever. It's easier, obviously, to do the vasectomy. So that would be something that they want us to at least make sure the patient's aware of and is considering. Risk factors for regret, you said less than 30 and parity less than 2, so 2 or less for sure. If they're in an unstable relationship, that would certainly be a risk factor for regret. Low socioeconomic status, if they have a child who's not well at home, if the decision is made in close proximity to a recent delivery, these would all be additional risk factors for tubal regret or tubal remorse. Okay, so here's where I thought you were going with the Parkland, and you almost went there. I would say, for all intents and purposes, this is what you said, even though you didn't say it in these words. That the reason you do the Parkland is because that's where you were trained. Is that what you wanted to say?
I mean, I was trained on Parkland and Pomeroy, but I've felt more comfortable with Parkland for quite some time. So yeah, basically.
Okay. I mean, either way, whether you wanted to or not, I'm sure there's folks on the call that would probably answer the question that way. We can't say that we're doing something because that's the way we were trained, even though that's what we all do. And the reason we can't say that is, if you were trained in Yoshida, I doubt you'd be spending the time and making the effort to do Yoshidas on all your patients. So, what I would say is, I have the most experience with this and I've had good outcomes. I mean, nobody can argue with you if you had good outcomes. I probably would not mention the bleeding on the mesosalpinx, however, because if you're really worried about that, as I kind of indirectly or directly pointed out to you, you really should be doing the pomeroy. And I'm not saying you should do a pomeroy over a Parkland or vice versa, but if your concern is bleeding of the meso, you're going to have it more often with the Parkland than you would with a pomeroy. If you think about it, it's kind of just logical because you're going into the meso
Right.
with the Parkland. So that would be my only, my only critique. The other thing I would suggest is, well, generally I do a Parkland of, again, good outcomes, plus I'm removing a good segment of tube, and the tubes are separated when the procedure's done. If the anatomy were such where I couldn't find an avascular area of the meso to make my hole, I would do a pomeroy. And that way it's like, you're not married to any one procedure, so they can't really kind of nail you on it, so to speak.
Okay.
Just another suggestion in terms of how to phrase it. Very good. Thank you for volunteering.
Cool. Thank you so much.
My pleasure. So let's see, Dr. Burton.
Hi.
How are you?
I'm doing well. Can I request a topic? Is that okay?
Boy, oh boy, you're getting pushy. If I'd known you were going to be like that, I would have called somebody. No, I'm kidding. Go ahead.
Oh, sorry. Okay. I was like, okay, that's fine.
No, I'm teasing with you.
Okay.
What is it
it's
you
just
want to request?
twins. I think that I have like quite a few. So I have a feeling I'll be asked something about them.
I'm happy to ask you about twins. I will tell you I am not a twin expert, having had very few of them, but I'm happy to ask you the questions, and I'm sure we have an MFM on the call who will be more than happy to go over and provide additional suggestions. I mean, again, high level, I got you, but detail we may want to involve our MFM.
Okay.
All right, so let's see. Sorry, just looking for them.
Okay. I had, I think, three vaginal times 2, and then one of them was a vaginal and then a crash.
Okay. So I see patient number 57 was a monodi set of twins. And she also had GBS bacteria. She was 35 weeks. You were doing increased antenatal surveillance. So why did you end up inducing? Are you with me?
I'm sorry.
Why did you end up inducing this patient at 35 weeks?
When the plan had actually already been put into place, but for this particular patient, she was uncomplicated enough that it was a reasonable time frame to deliver.
So why couldn't you let her go beyond 35 weeks? In other words, let's say to 36 weeks, or perhaps even, well, probably 36, no more than 37 weeks.
So based off of what I could see, it was just a conversation that she'd had with the providers taking care of her, and they had determined 35 weeks. There was no other specific reason that this patient was induced at that time, as opposed to later on.
So if you'd been managing this patient from the get-go, would you have recommended she be induced at the same time?
Not necessarily. So the recommendation for your Modi twins, assuming they are uncomplicated, is 34-0 to 37-6. So with you continuing your antenatal surveillance with your NSTs and then your growth ultrasounds, I think it's reasonable to even discuss, 37 weeks, just to try to reduce the risk with prematurity, etc.
Okay.
So I would try to push it out as long as I could, as long as it was safe.
Okay, I'm sorry. What was the gestational age you said again?
For timing of delivery for MODIs?
Yeah, for monodies, yeah.
So under uncomplicated would be 34-0 to 37-6.
Okay. So again, you said this patient was uncomplicated, would you have gone longer?
Yes.
What gestational age would you have recommended?
I would say 37 weeks, because at least your term.
Okay. How come you didn't give this patient steroids?
That is just going to be a mistake on my part. This patient had received steroids prior to induction. I didn't include it on the list.
Okay. All right. So I assume she only got one dose, is that right?
Correct.
So how come, how would you describe the risk-benefit analysis of, this was an elective induction at 35 weeks. You just told me she's uncomplicated. Mm-hmm. Looks like both babies are growing, reasonably symmetrically. So, why wouldn't you want to get 2 doses of steroids on, given the fact that she's only 35 weeks and this is, I'm not going to say it's an elective induction, but it's an elective induction.
In this particular case, my thought is that since there was a time planned for delivery and there had not been previous like preterm like concerns for preterm labor, that the 1 dose of steroids had been given with the plan to deliver within, you know, that 48-hour period or within a few days, as opposed to doing it sooner. So I can't answer that exactly, but since the plan had already been in place that she was going to deliver around the time of getting steroids, then it hadn't been that week between to do it again.
Okay, let me back up then. So are you suggesting that she received steroids before she came in for induction?
Correct, yes.
Oh, okay. I thought you gave her steroids when you started the induction.
Oh, I'm sorry. No, she received them previously in preparation for induction.
And did she get a full dose?
Yes.
Okay. So was twin B vertex as well?
Yes.
What are complications associated with monodi twins, or potential complications?
In general, you can. Have. So I'm on call, so I was getting a call. Sorry. With your monodi twins, you can have growth restriction with one. You can just have a growth discordance. You can have issues with presentation. You can have preterm labor, preterm delivery. In terms of the entirety of the pregnancy, she would be at higher risk for preeclampsia, diabetes, needing a cesarean section, any of those things.
What about how would you diagnose twin-to-twin transfusion?
So after chorionicity had been determined and they were found to be monochorionic, you would continue to monitor with ultrasounds, I believe at 16 weeks, and see, looking for the first stage, which would be your oligohydramnios in one, polyhydramnios in another, but it's just closer and more frequent ultrasounds to determine prior to that 20-week ultrasound.
So what would you do if you suspected a twin-to-twin transfusion syndrome?
So in our practice, our monochorionic twins are all managed by our MFMs, but my understanding is if there were to be twin-twin transfusion, there are certain things you can do, including ablating the AV anastomosis to try to diminish the effects of the twin-twin. And then it is really continuous monitoring and seeing how you do from there.
Okay. Let's see. All right, I think that is. I think that's it. Last question: if in a mono set of twins, what gestational age would you ideally deliver them? Actually, I have one more question after this.
Okay. For your monos, 32-0 to 34-0, if they're uncomplicated.
And what increased antenatal surveillance did you actually do for this patient, or what was done for this patient?
So this patient started with growth ultrasound starting at 28 weeks monthly, and then 32 weeks would have started the twice weekly NSTs, non-stress tests.
I got you.
No, I know. So I'm just trying to get away from using acronyms.
Yeah. Okay. So this really is the last question. So if you would have delivered this patient later, how come you acquiesced and delivered her at 35 weeks if you didn't think it was appropriate, especially for an elective induction?
Her induction had already been started by the time I came to the service, so I was continuing her care.
Okay, let's say that you had been on call and she arrives for an induction and she's 35 weeks. It hasn't been started yet. What would you have done? I
would talk to the patient first, and then I would actually speak with the provider who had put the plan in place just to see kind of how they arrived at that timing. And then there's always a potential to have that discussion again with the patient, saying the recommendation is you could be pregnant for another 2 weeks and 6 days, and then discussing the risk of prematurity at 35 weeks versus later on when she's reached term, and just continuing to have that discussion, and then leaving it up to her ultimately.
Okay. All right. Good job. I thought I think you did a nice job. Your timing was appropriate, 34 to 37 and 6. Don't necessarily think the 37 and 6 is critical, but a little odd at 35 with all else being good. If there were any hiccups on any of the antenatal surveillance, by all means, I could see it. Anything that would have prompted them to deliver earlier. But 35 weeks, I could even see I could even sign off or bite on 36. 35 is pushing it with no reason. I would suggest two things. It's important if this case were to come up. It's important to say that when you assumed care for this patient, the induction had already been started.
Okay.
And the other thing, if you are going to bring up the antenatal steroids, which I would think you would want to, she was given steroids in anticipation of this induction several days before. And again, you'd need to know what you would have done had you been managing the patient from the get-go.
Okay.
All right. Very good. Questions?
Thank you. No, thank you.
No. Thank you. I think you did a nice job.
Thanks.
Okay. Sure. Let's take a TV timeout here, guys, and we'll go over some questions, and then we will pick up again. So, will they ask us the time for the infusion, like IV hydralazine push over 2 minutes? They certainly could ask you if there's anything, any precautions you need to take when you're giving a patient a certain medication. And I mean, that would be pretty appropriate. And I think, the question even begets the answer. So obviously, you know the answer. Could we go over progesterone formulations and when you would choose a more or less androgenic progesterone in birth control pills? So we can certainly attempt to do that. The big thing is the newer generation progesterone. So your norgestimate, your drospirenone, your desogestrel are going to have a little bit less androgenic side effects. So usually less moody with for patients that are taking that, possibly a little bit less depression. Generally speaking, most birth control pills are going to be tolerated and are going to be, I'm air quoting here since you can't see me, are going to be roughly the same. There are certain situations where certain birth control pills may be more appropriate than others. If we talk about, for example, acne, well, there are some birth control pills that actually did the studies to show that that they reduce acne. But as we all know, the reality is birth control pills in general are going to increase sex hormone binding globulin, so they're all going to have some effect on acne, as an example, or unwanted hair growth. So that would be one thing to consider. But when we, really when we start getting into the PMDD, again, especially for bloating, that's where, a progesterone that has some diuretic properties and less androgenic side effects would be preferred. So that's where we're going to want to go with a newer generation progesterone. Again, the norgestimate and desogestrel are not going to have the diuretic effect that the drospirenone might, but they should be less androgenic in general, as they're a later generation progesterone. So hopefully that's given you enough to answer your question. That's pretty much what I could tell you. Can I repeat what the 50% stat was about salpingectomy? Yes. So patient that has a bilateral salpingectomy, so an opportunistic salpingectomy, for example, done at the time of hysterectomy, or a salpingectomy for sterilization, so complete salpingectomy. About 50% reduction in ovarian/peritoneal cancer is the thought. I've seen 40 to 60 most commonly, but again, I don't remember who was doing that question, but I have seen, I think it was Melissa, also seen numbers higher too. So her 65% I wouldn't say was incorrect. It's just not the number I personally would have used. All right, so that's all the questions we have in the question chat. So what I'm going to do now is I am going to lower everybody's hand for a minute. If there's anybody that has any questions or comments about anything that we talked about so far, please raise your hand now. I will take you off mute. We can go over the questions and then I'll ask for volunteers again. So right now for questions or comments. No questions or comments. All right. So if you could raise your hands again if you want to volunteer to be in the hot seat. Jessica? Jessica, I think you have yourself on mute.
Can you hear me now?
There you go. I can hear you now.
Excellent.
Are you a generalist or specialist?
I'm a generalist.
Okay, so I think we are up to office again, if I'm not mistaken. All right. Sorry, I'll be a second here.
Sure.
Okay, patient number 22 is a 30-year-old nulliparous patient with urinary urgency and frequency. Long story short, she had a UTI and you prescribed antibiotics. So what antibiotic do you use typically for an uncomplicated UTI in a non-pregnant patient?
I usually use Bactrim.
How long do you give it?
3 days.
Okay, what about if the patient were pregnant?
I generally start with macrobid for a week if they're pregnant.
Does macrobid have any complications or concerns in pregnancy?
Very, very rarely it does. Yes.
Can you be more specific?
Yes, I believe that use, and I get Bactrim and macrobid frequently confused during pregnancy. I believe if you use it in the 3rd trimester, they're at some increased risk of thrombocytopenia, perhaps.
I'm sorry, which one is thrombocytopenia in the 3rd trimester?
I believe macrobid, but I probably have that backwards.
Okay. What about in the 1st trimester? Any concern with macrobid?
Not that I can think of.
Okay. So can you use Bactrim in pregnancy?
Yes.
Through all 3 trimesters?
Avoid in the 3rd, I believe.
Avoid Bactrim in the 3rd.
Yes.
Why?
I frequently get Bactrim and macrobid. Which one is not in the 3rd? Not good in the 3rd, confused. I think macrobid is not good in the 1st because of risk of cardiac defects, and macrobid not good in, I'm sorry, and Bactrim not good in the 3rd due to thrombocytopenia. I'm revising my answer to be that. I know I just said
so
the opposite.
macrobid in the 1st due to cardiac, you said?
Yes.
Okay.
Like hypoplastic left heart is ringing a bell, but I don't think that
Okay, so from a technique standpoint, unless you're pretty certain of it, you said cardiac. let
Yes.
the examiner, if you're really uncertain, you're better off just letting the examiner, wait to see whether the examiner is going to say to you, like, which cardiac anomalies, because they may not ask you. And if they don't ask you, again, unless you're certain of hypoplastic left heart, you're better off not bringing it up, because if you're wrong, now they know you don't know, where before they would have assumed you knew which cardiac event, or they would know that you don't, they would not know that you don't know it. The double negative there. That makes sense.
Fair enough.
Okay. So what would you use? So you would use then Bactrim in the first trimester is what you're saying, since you want to avoid macrobid?
Yes.
And then the third trimester?
Or I would use ampicillin.
Or ampicillin. So which would you use?
Well, we have an oddly high incidence of penicillin allergies here, so I don't often prescribe ampicillin. So I would use Bactrim, and that is my standard go-to.
In the first trimester?
Yes.
Okay. And again, I'm assuming then macrobid in the second and third trimester?
Yes. And yes,
okay.
And Bactrim in the second trimester as well.
So Bactrim first or
macrobid.
second?
Yep.
Okay. What are risk factors for recurrent UTIs?
Postmenopausal women have more frequent recurrent UTIs. Prolapse, cystocele in particular, has more recurrent UTIs.
Why would cystocele have more UTIs?
I'm sorry, why would cystocele have more UTIs? Was that the question?
Yes.
Because cystocele changes the anatomic location of the bladder. So the way I kind of describe it to patients is that it's like your bladder is kind of folded and urine can get trapped in the part that's kind of hanging down. And you can have some retention issues because of that. And if you're retaining your urine, it's got a higher chance of growing the bacteria. So if you can restore the normal anatomy and put the bladder back where it belongs, it'll empty better and you'll reduce your risk of UTIs.
Okay. All right. So you were telling me postmenopausal, you told me prolapse or cystocele. I'm sorry, what else?
Some women do get frequent recurrent UTIs with intercourse, so postcoitally.
Okay.
And then there are some genetic or congenital conditions that cause increased risk of UTIs, like posterior urethral valves. Posterior urethral valves.
Okay.
Again, because of retention.
If you had a patient that was having recurrent UTIs, how would you manage her?
I would make sure that they were culture proven. I would see if there's any relationship between the timeline of her UTIs and other activities, like does she get a UTI every time she has intercourse? I would do an exam, see if she has any component of prolapse or vaginal atrophy.
What if she had postcoital UTIs? What would you recommend then?
I would recommend that she take Bactrim after intercourse. I'm sorry, macrobid after intercourse, or Bactrim. Both of them are valid options for this.
All right. I think we shall stop here. So good job on the uncomplicated UTI in a non-pregnant patient. Look, I'm not saying that everyone should say that they would use Bactrim, but Bactrim would be a good choice because it's only 3 days. And so compliance is going to be better, for example, than you might encounter with macrobid, again, in a non-pregnant patient. So concerns about antibiotics in pregnancy. So, both macrobid and Bactrim would not be the best choices in the first trimester. Macrobid, as you noted, can be associated with cardiac issues, cleft defects, as well as eye issues in the first trimester. Bactrim can be associated with neural tube defects, cardiac anomalies, and coanal atresia, as well as diaphragmatic hernia in patients when given in the first trimester. Macrobid, we have to be careful, as you may remember, late in the third trimester, so usually the last 3 weeks of pregnancy, and the concern there would be hemolytic anemia. So I am not familiar with bactrim causing thrombocytopenia in the third trimester. So if
I
anyone
agree.
knows
It definitely meant the hemolytic anemia.
yeah. And I think you did a nice job with the recurrent UTIs. The other thing you could do is, have the patient's partner shower and, wash well before intercourse. That may or may not improve or cut down on her frequency of postcoital UTIs. Very good. Any questions about this one?
No, thank you.
Thank you. All right, guys. So let's see. Lindsay, trying to get you off mute. Lindsay?
Hi.
There you go. How are you?
I'm good. How are you?
Good, thanks. Are you a generalist or specialist?
I am a generalist.
Okay. Let's see what we got here. Well, you have a bunch of perforated IUDs, huh?
Yes. I'm in a group. I'm not going to necessarily say I placed the IUD, but so.
Okay. So patient number 28 is a 54-year-old G2P1 with a symptomatic 14-week size fibroid uterus with abnormal uterine bleeding. The biopsy was insufficient. She declined conservative management. You did a TLH, BSO cystoscopy, and she had a benign serous cyst and hemorrhagic cystic follicle on the left. The right ovary was benign. How come you took both ovaries out?
So for this patient, I had counseled her on ovarian conservation, spoke with her about the benefits with regards to cardiovascular health, as well as bone health and overall even long-term mortality. However, due to her concern for reoperation and concern for ovarian cancer, she strongly desired the ovaries to be removed at time of surgery.
So what did you tell her the likelihood was that she would subsequently need to have one or both of those ovaries removed?
So like the risk of needing to be reoperated on for that. So the risk is very low. It's like 5%.
Okay. And you said she had concerns about ovarian cancer. So what is the incidence of ovarian cancer in the general population?
I am the general population. I'm not 100% sure on that, on the exact percentage.
So how did you counsel the patient then regarding her risks for ovarian cancer?
So, I mean, I counseled her that in the setting of not having any personal history of cancer, such as breast cancer, and no, significant family history, that her risk is low, and that wouldn't be a primary concern that I would have for her.
Okay. So if she'd been a BRCA patient, how high would her risk have been?
So for BRCA1, the risk is about 40%. For BRCA2, it's about 20%.
Okay. So by removing her ovaries at this time, in terms of her concern about ovarian cancer, does she still have a risk of ovarian or peritoneal cancer?
I believe she would still potentially have a risk of peritoneal cancer, but that risk would be very low, probably like less than 5%.
So less than 5%. Well, what do you, again, we don't know what the incidence of ovarian cancer is, right?
Mm-hmm.
Okay, I think we'll stop here. So ovarian conservation. So benefits were good, heart, bone, and longevity is the big one. So the reoperation rate, you said 5%, so very good. That's the number I would suggest you use. Incidence of ovarian cancer. So the incidence of ovarian cancer is 1 in 70 in the general population. So it's roughly 1.5%. If we were to do a BSO on this patient, we would reduce that 1.5% by 99%. So instead of 1 in 100, she'd be, what is it? 1 in 2,000. I guess it's 1 in 10,000 or something like that. It's reducing the 1% by 99%. So, you know, can do the math that way. I think that's about it. Now, the only other question, I guess, for this patient is she had abnormal bleeding, so she was not menopausal, right?
That is correct. She had not gone a full year without a period, so.
Yeah, so that's kind of, you know, then the question comes up, well, would you recommend hormone replacement therapy? So would you have, or did you?
For this patient, I believe I spoke with her about it. I'd have to double check if we actually started it or not.
Okay. I mean, there is no. Go ahead.
Sorry. Well, I was going to say, I mean, with the average age of, I mean, so for a patient whose ovaries were removed before the average age of menopause, I definitely would, for the benefits of the estrogen. But I believe for a patient, I feel like I had spoken with her about it if she was having symptoms in this case. But I understand what you're saying with her being not essentially, she's still premenopausal. So yeah, I'd have to double check on that.
Yeah. So, you know, there is no formal recommendation that if you're doing some, you know, hysterectomy on a patient who is not, and taking the ovaries, of course, who's not menopausal, but she's over the average age of menopause, that you should start her on hormone replacement therapy. However, you know, given that if she were 48 and not menopausal, we would have encouraged her to go on at least for 3 years. So this patient, we can't say that she's the equivalent of a 48-year-old or a 50-year-old, or, you know, because we just don't know. But this would be somebody that, you know, would not be, I would make an argument if asked on the boards that this would be a patient I would recommend goes on hormone replacement as long as there's no contraindications, at least for a period of time. And again, because I would want to try, and we have no way of knowing how long, by the way, but I would want to try to get her to the closer to the age of whatever she would have gone through menopause. Again, we have no way of knowing what things you could do. You could ask when her mom went through menopause, when her sisters, if she has any, went through menopause. And I believe there's some cursory calculators that they're trying to promote or propose to look at expected age of menopause. I'm not 100% on that. But it would be reasonable, even to put the patient on. And again, I'm not saying you have to, and if you didn't, that, you're going to fail or there's anything wrong about it. But again, I think we're in the absence of an absolute recommendation. This is the kind of question that would be a good question for them to ask, because it gives them a sense of how you think and what you recommend when you run into a situation for a patient that does not have a textbook case. It's like, how do you come up with your treatment decision? And whichever treatment recommendation you come up with, can you back it up, with what you otherwise know about OBGYN? So me personally, if I were arguing this, I would recommend she go on hormones. And again, if you ask me how, it would be completely arbitrary, especially if she didn't know when her mom went through menopause. And I would say, 2 to 3 years. But again, if she had side effects or didn't like it, I would tell her to stop. Or if she had contraindications, of course, I'm not going to put her on it. And if she refused, so be it. But I would explain to her, again, whatever the average age of menopause is, her body was not there yet. So she may be 54 years old chronologically, but her body's perceiving her as someone who's younger. Or her ovaries are anyway. Does that make sense?
Yeah, yes, sir.
Okay.
It makes sense. I think also with this case, it was hard to know if her bleeding was more from the fibroids or that it was hard to know if she was menopausal or not because of the bleeding. So yes, so that makes sense.
Right. And again, I'm not saying that if you didn't put her on it, you did the wrong thing at all.
Okay.
It's perfectly reasonable to do what you did. I'm just saying, if the question comes up, what would you recommend for the patient? You can imagine it could be a very interesting discussion. And this is an opportunity for them to assess your reasoning when there is no absolute, you should do this or you should do that.
Okay. Yes, that makes sense. And thank you for going over this, because this is something that I was concerned about, like the low age BSO. So thank you.
Well, I wouldn't consider her low age.
Well,
if she were menopausal,
before 65.
Yeah, I mean, 50. At 55, I think you're on pretty solid footing, especially if the patient, desires it. And you included the important things like heart, bone, and longevity is very important to mention.
Okay, thank you.
So, no, thank you. Okay, let's see where we go from here. Let's see if we can sneak in one more person. Jennifer, are you volunteering?
Yes, I am.
Okay. Are you a generalist or a specialist?
Generalist.
All right, give me 1 second. Here we go. Did we do cerclage the other night?
I missed one night, so I'm not sure.
Okay, let's do cerclage anyway. All right, so patient number 4 is 23-year-old G2P1 at 37 and 1, history of cervical insufficiency, although the patient was first seen at 29 weeks. Threatened preterm labor, diagnosed by her prior provider, growth restriction, medically indicated induction of labor. She had a persistent category 2. Again, the preterm labor was managed by her previous provider. Evaluation, counseling, and management of growth restriction. Counseling regard and management of fetal heart rate abnormalities. And she had a vacuum-assisted delivery, baby weight 1910 with 5 and 8 APGARs. So, what are your criteria for offering a patient a cerclage when you see them, let's say in the early second trimester?
So if the patient had a history of cervical insufficiency, so painless cervical dilation in the second trimester, she would be a candidate for cerclage that can be placed around the 12 to 14-week time period. If the patient had painless cervical dilation, excuse me, she would be a candidate for a rescue cerclage. Or if the patient had a history of a preterm birth less than 34 weeks, that was not due to a medical indication, so iatrogenic preterm birth, abruption, she would have cervical lengths perform starting at 16 weeks all the way to 24. And if the cervical length was less than 2.5 centimeters, she would also be a candidate for a cerclage.
What are the different types of cerclage?
History indicated, exam indicated, ultrasound indicated.
Right, so those are your indications, but what are the different types of cerclage?
You can have an abdominal cerclage, which those can stay in the patient for an extended period of time, even after, I guess, they've completed that pregnancy. Normally, those patients would require a cesarean delivery, McDonald cerclage, and Shidokar, I believe is how it's pronounced, cerclage.
All right. So McDonald and Shirodkar, as you insinuated, are two cerclages placed through the vaginal approach. So what's the difference between the two, and is one better than the other?
I am personally more familiar with the McDonald cerclage, but I believe with the Shirokar, sorry, I cannot pronounce that well. The bladder is kind of dissected off of the lower uterine segment and cervix, and it's placed a little bit closer to the endocervical canal. But I'm again more familiar with the McDonald, and with that one, whatever stitch is preferred. I prefer the Morse-Lane stitch, is just placed in a clockwise fashion around the cervix in order to enclose that endocervical canal.
So I'm sorry, did you say one is better than the other?
No.
Okay, so why would anyone go to the trouble of doing a Shirodkar? It sounds a lot more complicated.
I'm honestly not too sure. I guess thinking logically, if it's a more complicated procedure with a higher risk of complications to the amniotic sac, pregnancy, fetus, it must have a higher efficacy.
What are your criteria in a patient with no history of preterm labor or delivery? What would be your criteria for recommending vaginal progesterone?
So if the patient had a shortened cervix that's less than 20 millimeters, they're a candidate for vaginal progesterone. There are patients, though, that if they don't have a history of preterm labor, but their cervix is as short as 10 millimeters, they can be a candidate for a cerclage.
Okay, so basically incidentally found is what you're saying?
Yes.
Okay, I think we shall stop here and go over it. So good job. Cerclage. So there's three types, as you mentioned. History indicated, again, that would be somebody with a history of painless dilatation who usually results in a miscarriage in the second trimester, or someone who's had a cerclage placed in a prior pregnancy for an appropriate indication. So basically a history that goes with painless dilatation, aka cervical insufficiency, or she had a cerclage placed in the past, again, for an appropriate reason. Rescue cerclage would be, some would construe or call that an exam indicated cerclage. So somebody who has dilation usually with some effacement of the cervix would be in the second trimester would be another indication. And then, as you mentioned, the ultrasound indication. So somebody with a history of preterm delivery less than 34 weeks would have cervical lengths between 16 and 24 weeks done every 2 weeks. And if the cervical length was found to be less than 2.5 centimeters or 25 millimeters, they would also be a candidate for cerclage. So I think your description of the McDonald being a purse string cerclage and a Sherrod car, basically you're dissecting it's almost like the first step of a vag his, where you're dissecting the bladder off anteriorly and pushing it up higher. As you originally said, it is not more efficacious than a McDonald cerclage. The only reason anybody would do a Sherrod car is if there's not enough cervical length to place a McDonald. It used to be thought that it was more effective, but studies haven't shown that to be the case. So again, only reserved for patients where there's not enough room to place a McDonald. Abdominal cerclage, and I didn't ask you this, would be for a patient who's failed a previous vaginal cerclage, who's had a trachelectomy, or there's not enough room to place cervical cerclage. All right, so vaginal progesterone. So what you gave me, Lindsay, was the old number. I'm sorry, Jennifer, was the old number. It used to be 20 millimeters, and now they say that if they're less than 25 millimeters, they are a candidate for vaginal progesterone. So no other history, but an incidentally found cervical length of 25 millimeters or less. And as you correctly pointed out at the end, 10 millimeters or less for an incidental finding, let's say on an anatomy scan, what have you, that would be a patient as well that you could offer you could offer a cerclage. I think that is it. Are there any questions that you have, Jennifer?
For the abdominal cerclage, that has to be placed prior to pregnancy, is that right?
It's typically placed prior to pregnancy. To my knowledge, it can be placed during pregnancy as well, but the preference would be to place it prior to pregnancy.
Okay, thank you very much.
Thank you. Okay, so I'm going to put everybody's hand down, and let's go to the questions, which will, let's see, my understanding is late preterm steroids are not universally recommended for twins. The SFM consult recommends shared decision making. So typically going to be my understanding is it's going to be a little bit less critical for twins because the added stress of the twin pregnancy, but certainly something that you would definitely want to talk to the patient about and come to a mutual understanding. I mean, the shared decision making, even if you had a 30-week patient, I would suggest it's going to still be shared decision making. I understand the point though that the commenter is making, and thank you for it. Let's see, would ampicillin be the right answer for first trimester then? So certainly ampicillin would be something that could be used for first trimester. Augmentin could be used in the first trimester. Keflex could be used in the first trimester as well. So these would all be medications that could be used in the first trimester for UTI. All right, so midazolam is the preferred IM benzo when there is no IV access, 10 milligrams once versus IM lorazepam because of varied absorption. IV lorazepam is preferred benzodiazepine when IV access is available. Thank you for sharing that with us. Appreciate it. Could I repeat the effects of bactrim and macrobid in the first and third trimesters? So macrobid, the concern there in the third trimester, and this is usually in the last 3 weeks of pregnancy, or 2 to 3 weeks of pregnancy, would be hemolytic anemia in the newborn. Not common, but that is the concern, which is why it's not recommended late in pregnancy. In terms of, give me 1 second here, guys. In terms of first trimester issues, macrobid, potential eye, heart, and cleft defects with macrobid in the first trimester. And with bactrim, the concern is neural tube defects, cardiac anomalies, and coanal atresia, as well as potentially an increased risk in diaphragmatic hernia. So those are the potential complications and effects. Let's see. Oh, I'm sorry. Somebody had a PPX, and I just erased your question. I apologize. I meant to open it, and I hit the trash can. So whoever was writing about the PPX, please write it back in, if you could, please. For the patient who has a BSO before menopause, and you discuss managing menopausal symptoms after surgery, but the patient has increased risk for clots like smoking, diabetes, obesity, hypertension, and/or hyperlipidemia. Would it be okay to say that you discussed the risk benefits and decided that non-hormonal methods were recommended for the patient rather than hormone replacement, although these are not contraindications to hormone replacement? So to be honest with you, smoking is not a contraindication. If the patient herself obviously has a history of blood clots, that's a whole different story. But diabetes would not preclude me from offering a patient hormone replacement or recommending it. Same thing with obesity. You would need to explain to the patient that she does have these increased risks, but these would be patients that I would also be much more strongly encourage, if she is going to go on hormone replacement, to go on the transdermal approach to help counteract some of her increased risk by using the transdermal method, which will bypass the liver and therefore, in theory, at least reduce the risk of her developing a DVT. So again, obviously it's all going to be shared decision making. And of course, you're going to want to counsel the patient that her smoking, obesity does put her and smoking and obesity does put her at increased risk for DVT. Hypertension, I would argue, probably not so much increased risk for DVT, perhaps increased risk for stroke, but we know that strokes are not increased, especially with estrogen alone, but with either actually until patients are in their 70s statistically. So if we're talking about a patient who's in her early 50s, statistically, again, she would actually reduce her risk of stroke. So hopefully that answers your question. Let's see. So if you do a postpartum BSO on a premenopausal patient, age 30 to 40, for severe endometriosis, could that be considered a contraindication to HRT? It's not really a contraindication to HRT. The question the question that comes up is, what should you do with that patient? Should you offer her and start her on hormone replacement therapy straight away? There's two schools of thought. One is to start her and offer her right away, particularly one, she's going to be symptomatic, and two, she's pretty doggone young to be without hormones. Now, the other school of thought is, do you wait 6 months like you would treat somebody, for example, with Lupron for 6 months to, quote, I'm air quoting here since you can't see me, to mop up any residual endometriosis or endometriotic implants. So there is no right or wrong answer. You can certainly make a case for either, but that's a patient that you're actually going to want to start on hormone replacement therapy. I mean, that's quite a young age to be deprived of estrogen and the benefits for her bones as well as her heart. So again, you may end up having to put her on estrogen and progesterone both if she starts developing symptoms from the endometriosis. If you can get away with a super low dose of hormones, which you could try, and you certainly would start low and titrate up as needed. But if you could get away with a super low dose, it may not stimulate the endometrial glands that may be still residing in her pelvis. Usually, again, younger patients are going to require higher dose. So that may be where you would consider birth control pills. Okay, thank you for resubmitting that question. Excuse me, can I speak on 17-hydroxyprogesterone for history of preterm birth? Some studies show there's no benefit. I know ACOG still recommends, if I'm not mistaken, how should we go about answering if we don't give it in our practice? So it is a bit controversial. Certainly the McKenna is very controversial. You can give, for patients that have a history of preterm delivery before 37 weeks, you can give those patients, you could still give them McKenna or IM progesterone for sure weekly. You could also put those patients on vaginal progesterone would be another acceptable option. I think if you don't recommend it in your practice, my suggestion would be, and again, I'm not suggesting to be dishonest, of course, but my suggestion would be that that you explain to the board or to the examiners that you have a discussion with your patient. You tell them pros and cons of treating with progesterone, and in the end, you come to a shared decision making. Again, a lot of people are still using progesterone. I'm not saying it's right, and I'm not saying it's wrong, but it's certainly controversial, as the Inquirer is pointing out here. So if you don't recommend it, that's fine, but that doesn't mean you can make the decision. You still need to counsel the patient and come to a joint agreement, because ultimately it's going to be her choice. So that would be my suggestion in terms of how to approach that. Okay, last question here. Can I please repeat the indications for vaginal estrogen and short cervix? So it wasn't for vaginal estrogen, it was vaginal progesterone. And so somebody who's found incidentally to have a cervical length of less than 25 millimeters would be a candidate for vaginal progesterone. So yeah, and we just talked about the other instance where for somebody with a history of preterm delivery who would be a candidate also for IM progesterone, vaginal progesterone, or she may choose not to use progesterone at all, but again, shared decision making there. Okay, let's see. For McKenna would be pain. For vaginal progesterone, could you say it's messy? You can say it's messy, and you can say McKenna and the injection would cause some discomfort. I guess I'm missing on the context of, I mean, yes, both are potentially true, but you know, that's still not going to preclude you from offering the patient progesterone if she's an appropriate candidate. So, not sure the context of the question beyond what's written there. Okay, so I think we've gotten through all the questions in the question box. This is last call. So sorry to keep you guys later than an hour and a half. This is last call. Raise your hand if you have any questions or comments before we wrap up. Jennifer? Jennifer, I'm trying to unmute you.
Okay.
There you go.
Sorry, just for the pros, of course, I would know what to tell the examiners I discussed with the patient, but I guess I'm just trying to think of what are good cons. Like for McKenna, it's the shot can be painful. For the vaginal progesterone, I don't know what I can think of to say besides.
Yeah, I don't think you need to tell them anything about, I mean, people know that shots are usually have some discomfort associated with it. I don't think it's really, I think the con here, honestly, is more the data is conflicting, at least for the 17-hydroxyprogesterone in your preterm labor patients. Okay. I think that's probably the biggest con is, what's the right thing to do.
Okay. All right. Thank you.
Thanks. All right. So I thought vaginal progesterone was still only recommended if it was first pregnancy less than 20 millimeters. My understanding is it's 25 millimeters and it doesn't have to be first pregnancy. It's an incidentally found shortened cervix less than 25 millimeters. And I'm certain of the number. I don't believe it's only first pregnancy. One last question. If you mix up some information and catch onto it later in your response, what's the best way to go back and straighten yourself out? Well, it depends how big a hole you've dug for yourself. If you really have gone down the rabbit hole and, just said something that's completely outlandish, I mean, you can certainly go back and say, hey, I think I misspoke before when I said that, the main cause of abnormal fetal heart tracing was, I don't know. I can't even think of a good example. If you said something really outlandish, I think you can correct yourself, but you've already kind of the damage can be done if you've said something that's just so outlandish that makes it look like you have no idea what you're talking about. So that's why I tell people, if you have a reasonable idea, if you don't know the answer to something, you have a reasonable idea, by all means, feel free to volunteer it. But if you're really guessing and have zero idea, you're better off just saying you don't know. Because sometimes you can say something that is so far incorrect that it not only shows you didn't know the answer to that question, but it shows maybe you don't have a good understanding of some of the other physiology or some of the other pharmacology or whatever. So you have to be a little bit careful with that. I had a candidate several years ago who we were talking about cerclage, and he told me, I asked when he would remove an abdominal cerclage, and he said, well, when she comes in labor, I'm going to, remove the abdominal cerclage. And I'm like, how are you going to, or no, I'm sorry. He didn't say when she comes in labor. He says, well, while she's laboring, if she runs into, arrest of dilation, he was going to remove the cerclage then. I'm like, what? I mean, it was so far asunder that it just showed that this person had absolutely no idea about cerclages. So they went from, I'm not sure when I would remove it, or I don't need to remove it, or who knows what, from something that could have been neutral to this person's clueless and bordering on dangerous. A little scary, because they're going to let somebody labor with an abdominal cerclage. That'd be a big oops. So again, be careful. Totally going out on a limb and guessing. In most instances, especially if it's not an emergent situation, you're better off in that case saying, I don't know. Okay, guys, thank you for your attention. Sorry to keep you a little bit after school, so to speak. Good luck with your continued studying, and I will look forward to speaking with you all later in the month. Have a great evening. Good night.